So this is the last video I have to make for my first exam. So let's get right into it. So aldosterone is a sodium retention hormone. It's made from the adrenal cortex. And yeah. So what does this mean? So more aldosterone means you're keeping more sodium, and therefore the inverse is true. Less aldosterone, less sodium. It's the same thing kind of as vasopressin, except for sodium, right? Let's see, what else do I gotta do? I'm gonna do growth hormone this video. Oh, did I do aldosterone already? No, I didn't. Yeah, no, I didn't do aldosterone. Good. So I'm gonna do aldosterone, growth hormone, insulin glucagon, calcitonin, vitamin D, parathyroid hormone. Okay. Let's see. Let's do insulin and glucagon. So insulin is the peptide hormone. From the pancreas. So if it's a peptide hormone, what does that mean? It's gonna be binded on the cell membrane, and so what it does is it'll decrease blood sugar after a meal, because after you eat, your blood sugar is going to increase, and so you're going to need insulin. And so what this does is insulin's gonna bind to receptor. So step one is going to bind to receptor. Then this will create a signaling pathway. So there's a metabolic receptor. So it'll create a signaling pathway that tells the cytoplasmic vesicles to insert GLUT4 transports into the membrane. So it tells cytoplasm and so what does that do? Increased glucose inside cells. So the way insulin works is that it'll move the sugar from your blood to inside the cells. And so if the blood has if the cells have more glucose, it's going to be working more, right? And yeah. And then the next one is glucagon. What glucagon does is it opposes, with two P's, opposes insulin. So insulin reduces blood sugar. This will be increasing blood sugar. So what this does is going to stimulate glycogenolysis, gluconeogenesis, and ketone synthesis. This is just a fancy word for more sugar. Another fancy word for more sugar. And this is just is energy used by the brain. And so yeah, that's pretty much what it does. And so I have to talk about diabetes. So diabetes, wow, I cannot spell today. Alright, T1, there's two types, T1, T2. T1 is the autoimmune disease. So this is the beta cells don't work, so you're not gonna create enough let's see, beta cells don't work. Yeah, so you're not gonna have enough not enough insulin. So you're not going to create enough because your autoimmune is attacking the beta cells. So you're not going to create enough. Then there's type 2. Type 2 is the one that really adults usually get. And this is where you make enough, but there's decreased responsiveness. Like you see, in this case, beta cells are fine, but sensitivity to insulin is decreased, or the response to glucose is impaired. And so this is really the more common case. The other one is, like, I think pretty much genetic, and like some kind of treatments would just depend on the person. And so yeah, there's also gestational, which I'll write in purple. Gestational, which means the mother is gonna not the mother, but actually, yeah, I think it is the mother. So what's going on is, in a normal pregnancy, right? Here's step 1. Pancreas is gonna undergo hypertrophy and hyperplasia, And these are just fancy words for strength gain or growth. And this is more cells. So more cells, growth. It's around the same thing. To meet the demands. So they're going to grow to meet the demands of pregnancy. And so step 2 is you're going to have an increased insulin resistance. And decreased insulin sensitivity. Because if you have too much insulin, your baby is not going to get enough glucose. So this is why that has to happen. So baby can get glucose. So then baby can get glucose, and then step 3 is after delivery, pregnancy hormones gone. Which means everything turns back to normal. However, within gestational diabetes, this step does not happen. What does that mean? You have a normal sized pancreas, and this means the pancreas cannot handle the amount of insulin and the amount of insulin increase, the resistance in insulin. So your baby gets too much sugar, and so if it gets too much sugar, your baby's just gonna end up huge, like much bigger, and you're just gonna have to end up with a C-section. And so that's usually what really happens for gestational diabetes. And yeah, that's pretty much it for glucagon and insulin. Let's go into growth hormone. I think growth hormone, parathyroid, and calcitonin are all kind of related. So let's go right into growth hormone. So you can see with growth hormone is, well, growth. That's the purpose. So you can see muscles and bone growth from growth hormone, also known as growth hormone releasing hormone. So I'm guessing this is an interrelated one, like the other hormones, where if your body needs to grow, your body's like, hey, let's have a lot of these, so you can tell the body to make more growth hormone. So another kind of connection there. So growth hormone has an anti-insulin effect. Because it needs the glucose, right? You need glucose to grow. What's going to do is going to increase your blood sugar to increase glucose production in the liver. It's going to break down fat. You're going to build muscle. You're going to build some other stuff, and you're going to need to increase amino acid uptake into the muscle cells, right? That's why it has an anti-insulin effect, because you need the glucose. Growth hormone is really controlled, is most released during sleep, and has a circadian rhythm, so hence is why it's most released during sleep, and it's highest during adolescence. And like the thing with growth hormone, like because you need the glucose to grow, if you have too much growth hormone, that might lead to diabetes. And if any of you guys know Chris Bumstead, my friend said he's on growth hormone, and he might, he has, like, taking this growth hormone gives him a risk for diabetes, and I'm scared for the guy now, but he should be okay. I mean, he's pretty fit, so it's fine. Anyways, that was a tangent. You have some kind of conditions that are associated with growth hormone is GH insensitivity hormone, where you have it's released but the receptors don't respond. So what does that mean? You're just not going to grow, right? Another thing is acromegaly, too much GH during adulthood. The bones increase in size. Bones increase in size and affects adults in middle age. So, like, this is kind of how, like, the growth is. Like, you grow a lot during adolescence, right? And then you're just gonna start, like, kind of plateauing as you age, right? Or even, like, worsening, rather. What this does is just gonna extend that into adulthood. So that first plateau, like puberty, you're going to extend that to adulthood as well. So that's really what this is. Some people take growth replacement therapy, growth hormone replacement therapy. It's there's some ethical stuff behind it, but it's prescribed to kids with a documented growth hormone deficiency, and therefore it will help them grow. Alright. So, talked about that. Calcium. So, before we talk about the parathyroid and the calcitonin and vitamin D, right? So, growth hormone, yes. So, all we're missing is vitamin D, calcitonin, and parathyroid hormone. So, before we talk about that, let's talk about the bones. So, the bones, obviously, you need calcium. And so there's two kinds of bone cells. There's osteoblasts and osteoclasts. You think of I think of blast. Oh. So what the blast do is they break, and the clast do is they create. Or no. That is wrong. The blast, what they do is they build, and the C is they break. I guess a way to remember this. Because the issue with like this is kind of confusing. That like it starts with blast, so you're gonna think of like it breaks, but like it builds, so it's like the opposite. So I'm just gonna think, okay, blast, opposite. So if it isn't breaking, it's gonna build. All right, that's another tangent. So then, you need calcium to build bones, and so hormones that favor the bone formation is growth hormone, estrogen, IGF-1, calcitonin. Bones that favor bone breakdown, like cortisol, thyroid hormone, and parathyroid hormone, which are the two we're about to talk about, or some of them are the ones that we're going to talk about. So we have parathyroid hormone. So the goal with parathyroid hormone is to increase blood calcium levels. And so what this does is, say you are low on calcium, what it's going to do is going to increase osteoclast activity. Will accomplish this by increasing osteoclast activity. So it's going to break down bone, right? It's going to increase intestinal absorption. Of calcium. So you're going to get more calcium from your food. Calcium reabsorption in the kidney. Increase calcium reabsorption from kidney. Is where like you're not going to pee out calcium or as much calcium, because you're going to reabsorb it into your body, and then you're going to decrease phosphate reabsorption, because phosphate will make it so that you have less calcium because they bind together. So if you have less phosphate, you'll technically have more calcium to be used. Okay, so this is what parathyroid hormone does. It's also known as PTH. So that's another way to think about it. That's another way to call it. So then we have vitamin D. Is the sunlight vitamin, but it's also a hormone because it's made by your skin. So call it what you want. This is what I need to know for my exam. So I'm calling it a hormone. and the vitamin. So what this does is this will stimulate intestinal absorption of calcium, and so it works with PTH. And so having a deficiency will mean you're more prone to bone breaks and stuff like that, or like fractures, bone breaks. Is a vitamin and a hormone? Calcium absorbs calcium. And vitamin D does a lot, but this is really the most important thing, where it assists parathyroid hormone's job, in that these two have kind of the same function. Alright, and now what's the opposite? Calcitonin. Calcitonin is the opposite, where it's going to lower blood Ca2 plus levels. So what it's going to do is may stimulate further, will stim osteoblast activity, meaning it's going to make some bones now. It's going to use up the calcium levels, the high calcium levels, to make some bones. Or, yeah, that's all I have about it in my notes. So this is what it does. Yeah, really, that's all I have in my notes. Alright, and so then we're going to talk about osteoporosis. I'm sure you guys have heard of it, but this is just too much bone breakdown and not enough formation. So too much breakdown means osteoclast activity, and then not enough osteoblast activity. This means if you're breaking down your bone too much, that means your bones are too fragile. You have a predisposition for fractures. You see this more with aging, and it's more common in women because post-menopause you don't have estrogen, and estrogen is one of the like a bone protecting hormone, and the way to fight against it is, well, strength training. Strength training will increase bone growth through adaptation, and will help with when you're dealing with osteoporosis. Then there's also osteoarthritis. Osteoarthritis, what this does is soreness in bones and joints. This is caused by the breakdown of cartilage between the joints, and the treatment is strength training. And that's why working out is OP, because it just solves this, right? All of your bone problems, it just, strength training kind of just solves. And so yeah, that's it. That's all the information I have to cover for the first exam. Thank you for watching. Actually, I have one more. This is way back. I'm going to talk about another drug called Narcan. So when I was talking about all the drugs like opioids, SSRIs, antidepressants, anti-anxiety meds, cocaine, there's one more, and we're going to talk about Narcan. So we're going to have dopamine here. We're going to have the synaptic vesicles. We're going to have the intermodular neuron. So we're going to do, what opioids do, right? It's going to block this, so then this will continue sending a lot of dopamine, right? So what if we had a drug that blocked the opioids? So that allows this to work then. That allows this to work, so then you're not going to get any dopamine. In fact, it allows this to do its job, so it'll regulate how much dopamine this will send. That means you're going to get much less dopamine in the synaptic cleft, and so that's what it does. Yeah. And that's it. Thank you for watching my Exam 1 series. I will be making more videos on Exam 2.